Yeah, hello and welcome to another video on my channel here. We are, stressing the topic CCI, Cranio Cervical Instability, with a focus on the German language-based areas. However, if you want to talk about CCI, you need to have the American experts. Today, I'm very happy to have Brian Hutchason for a second time on my channel. If you are German speaking, I would do a German translation, so you can also look on my channel on the German version of this video. And for all other listeners, I hope that this video will also bring some new insights for you, because we are striving a very special topic today. I have not seen it touched so much right now on the international channels on the topic CCI. It's tendinous instability. So that's a new frame, a new name for me. And Brian, I'm very happy to talk with you about it today.
You so much, Uli. I'm delighted to be back speaking with you today. Just the conversations that we've had have been really wonderful, and what you're doing for people in Germany and in Europe just to raise awareness to varieties of upper cervical injuries is remarkable. So thank you for what you're doing for the benefit of the
Yeah.
community.
I'm hoping, because I realize that also now artificial intelligence can translate, that we can even exchange more without translation issues always automatically very soon also on YouTube, I hope, because I've seen very prosperous technologies on that, where the translation is with your own voice in all languages. I hope this is coming soon also on YouTube, but unless there, I do my best to talk in English with you. Brian, what is a tendon, and
So,
why can there be tendinous instability?
well, tendon is the connective tissue that actually moves your bones through space. So tendons are on either side of muscle bellies, and they're the fibrous connective tissue that when that muscle is activated, they're the kind of the hinge that pulls the bone to create motion. So tendons help us with motion, and they also are half of spinal stability, the other half being the ligaments.
So when you think they are responsible for stability, they are responsible that the muscle can work properly, right? It's not a direct stability factor, but it's indirectly through a very good muscular movement. Is this the case?
It's kind of yes. It's a more dynamic form of stability. So when you have strong and healthy tendons, they're an appropriate length, meaning that they haven't been over time stretched out and become weaker and become longer, to which point that they will produce more of like the muscle or the tendon always clicks over the spot it's supposed to be in. This can happen with, more commonly with the bicep tendon that connects up closer to the shoulder. Other ones can do this as well near the knee. Some of the adductors and also lateral, tendons around the knee can kind of click over the spot, that the groove that they're supposed to be in. So tendons provide stability through, yes, a strong tendon and strong muscle in a static position, and also dynamically when you're moving, they control how the bones will move in relation to one another.
Okay. Now, very basic question: why can a muscle not directly be fixed to a bone? Why you really need a tendon?
Really need the tendon because it's kind of like an anchor. So I am going to try to make a good comparison, but um, when you have a sailboat and you put the sail up into the wind, you could maybe look at that as a parallel to the muscle belly, which is adaptable and free to move. But where the actual sail gets connected to the boat has to be a much firmer, much more rigid connection in order to create the strength and stability to withstand, repetitive forces and, other various things. So if you only had the muscle connecting to the bone, it would be much more easy to tear it, and then you wouldn't have any coordination between your bones.
Okay. So let's come to the basic question. What is tendinous instability?
Tendinous instability is basically when you have tendinopathy, which is a chronic degeneration or a chronic degenerative process of a tendon. And this can happen from a multitude of reasons. The most common that we find in our practice, Uli, is from overuse or repetitive strain sprain. So an individual that's sat in less than ideal posture for 10 or 20 years and has just experienced a chronic stress and stretching of the tendon, to which point that it doesn't return anymore to its normal length and integrity. There's a couple of really good books on this, but it shows that when an individual is subjected to 8 hours a day of a certain kind of labor, whether they're manual labor or sitting on a computer, and they're in one position for the whole day, whether they're turning a wrench 8 hours a day, or they're sitting like this 8 hours a day, or they're overhead painting 8 hours a day, or whatever that it is you're doing, that your body needs almost a full day to recover from that, to get into a neutral position. And that stretch that you created on your tendons and your ligaments is going to kind of revert back to normal. But when you have that repetitiveness of, you may work 8 or 10 hours, and then you wake up the next morning and you just keep doing it again and again and again, over time, the connective tissue, tendons and ligaments don't have a chance to fully return to their normal length and to really give themselves a chance to heal. So over time, they're repetitively stretched, elongated, eventually creating micro tears in the tissue, discoordination. And then I'm sure you're going to ask me more about it. So I'll let you ask the next question.
Right. You mentioned already how a tendon can be harmed by just, putting force in a wrong way without a lot of movement. Yeah. But I remember in one of the last video we did together, you said also the tendon is the first point in the body which gets harmed in terms of when an accident occurs, right?
If you're aware that it's going to occur. So yes, if your body's able to brace before you experience an impact, like let's say you're falling and you're falling and you squeeze your body as tight as you can, the primary force is going to go into the tendons first. So the muscles will contract fully and the tendons will try to prevent any, excessive motion between bones and stabilize the fall. And then once they no longer can do their job of supporting, and you may also get some of the more superficial ligaments to initially get that impact, then the force starts to go deeper into the spine, into the capsular ligaments, into the really deep ligaments, which there are so many. I could start listing them, but if you're completely unaware that you're going to experience a trauma, like let's say that I'm sitting at a sports bar and I'm watching the big game on TV, and I'm just laughing and talking and sitting there, and somebody just absolutely clocks you in the side of the head while you're not paying any attention. Your muscles are somewhat relaxed, so you're going to quickly get to the end range of motion, and then your ligaments will get more of the force. And then probably lastly, as your body's able to clench down, your muscles and tendons will try to also absorb some of that impact. That's why it's a big question, and we talked about this before, that if you do work in like a personal injury realm, they want to know, were you aware of the impending injury? Because if you were aware and you could brace, you're likely going to get more of it into the tendons, and which is a bit easier to recover from than some of the really deep ligaments, which may require more invasive treatments or produce a more severe type of instability.
Okay, when a tendon is harmed, is there kind of silent inflammation there, or is the structure changed? Is it more tight or is it more loose? Can you describe how it looks like to have a harmed tendon?
Sure. So initially, you'll get typical swelling, and your body will try to produce a healing inflammatory response where it works to really try to heal that tendon the best that it can on its own. And that initial period of several weeks or a month is the ideal time to try to create a healing scenario. So to be in positions that aren't going to put excessive force on the tendons, to be doing very gentle types of mobility to allow circulation and blood flow, to control the inflammation, but not eliminate it. So if it gets out of control, to maybe just minimize it a little bit, but not to take away all of that ability to heal. I think that once it gets to a more long-standing type of inflammation or a chronic degenerative process, then the signs and symptoms can vary. And so they can vary in many ways, because when a tendon has experienced tendinopathy or chronic degeneration, it has nerve ingrowth in the area. And that's partially because of it's trying to heal. So it upregulates expression of certain things that are going to be more likely for new nerves to come near there. Also, sometimes little tiny circulation pathways are created, like angiogenesis will happen around that tendon in an attempt to heal, but it can do it in a faulty way if it's not always an ideal healing process. So then the tendon becomes more stiff. It also is more rigid, not quite as pliable over time, because there's new nerves in the way where the tendon should have tendon fibers. It now has, these micro nerve ingrowths and little tiny blood vessels that shouldn't be there. So it's more stiff and less pliable. And it also, over time, if either immediately, depending on severity of the injury, or over time in a chronic degenerative process, it can become elongated, which also can increase the amount of tendinous instability if that tendon is lengthened beyond its normal length.
Okay. Can you differentiate between a tendinous instability or a ligamental instability? Is there some signs you can see in the terms of the behavior of the vertebrae, of the instability, or is it just you need to check?
Yeah, the short answer is yes and no. So sometimes it's very obvious that the kind of instability you have is going to be more one than the other. Let's say an example is that, you watch a digital motion X-ray and you see there's 7 or 8 millimeters of lateral overhang to one side, and it's somebody that otherwise has a pretty athletic and strong neck. Then, you're thinking that there's definitely a big component that's ligamentous. It's really, I think there's not a one size fits all answer to this. Almost every time, Uli, somebody that has instability is going to have a bit of both the tendons and the ligaments, because all of those, there's ligaments and tendons that are supporting the same area, just on different depths and in different spaces in the front, the back, closer to the bone, further from the bone. And well, they all connect to the bone, but on one angle. So in the front, there might be a ligament right in the middle, but just to the side of that, maybe the longus capitis, which has a tendon that connects also pretty nearby to some of the ligaments. So it's very often that you're going to have a combination of both.
Sure. Okay, but there are some indication where you say, oh, it could be triggered by tendons, or it could be triggered more by ligaments. Yeah.
I see dural buckling or infolding without other signs that there's a huge or significant amount of ligamentous instability. I'm usually suspecting that there's some suboccipital tendinopathy, which you also can look for some of these spinal stabilizers in the upper neck. You can look for the multifidus if it's atrophied on certain MRI images to confirm that. And we're having pretty good success at treating the suboccipital tendons and creating changes for people that thought otherwise, that either they had no hope or they were just waiting patiently for the country that they live in to approve a surgery that they were having a hard time getting approved. So there are certain indications we can tell that it's more tendons. One example that I think is more common to be a tendon is when we have tilting of the atlas or the occiput on a neutral lateral view, and we're able to remove the weight of the arm of pulling down on the neck, and then the tilting eliminates. So typically that's related to pulling, and pulling is going to be more related to tendons than it is to ligaments. Of course, if you have extreme instability, the muscles and tendons do adapt and will create pulling and tension. But also it's pretty neat because more and more often I'm seeing that if we can eliminate pulling from one side of the arm, that the tilting will eliminate or reduce. And then I can build a plan to start to strengthen the tendons that are pulling the neck out of alignment and reduce one form of upper cervical instability.
Okay. You know, I'm quite interested in the CCI topic, and I'm following also all the US channels on the topic. From tendinous instability, I've just heard from you. Are you the discoverer of this type of instability?
Uh, I wouldn't say that I'm the discoverer of it, but I think that many people that have done dry needling to the suboccipital region, that they may not have focused exclusively on creating enough of a precise irritation on the tendons to create a really, really strong stability factor or stability enhancement. And that's been something that I've been, I guess, on my own dialing into and figuring out how to do this in a way that provides pretty long-term results in relief for individuals. I stressed before that it's really important, in my opinion, that you're not dry needling into the muscles in the suboccipital region or often really anywhere in the neck. Usually the muscle tightness, the muscle weakness, the discoordination, the activation of a different muscle when you're trying to activate the other muscle, that these are due to degenerated and weakened tendons and ligaments, not to a muscle trigger point. And so I think that if I'm still staying on topic for your question, was that I found that in certain individuals, whether they had signs of ligamentous instability or they didn't have many signs of ligamentous instability, that I've been able to get immediate and long-lasting changes for the better in many of the signs of having suboccipital tendinopathy, degenerated tendons, a form of upper cervical instability that people have not been able to get results with other forms of treatment or this specific type of approach for the tendon dry needling. So remember, people using a needle to bring healing has been around since the beginnings of, archaeological findings. I mean, I think it was 7,000 years ago that they found some ancient wooden tools that people in Asia had used, and they were pretty gruesome and primitive, but probably every kind of needling therapy that could be done is close to have been done now in 2024. But I think that it's using the needle is not inherently good or bad. So I'm going off on a tangent, but it's how you use it for that one individual. It's like not everybody would benefit from decompression or traction treatment. Not everybody would benefit from, so there's no one treatment that's, perfect for everybody, but I'm going off on a tangent. So I don't want to say that I'm the first one to ever do it, but I think just the way that I'm doing it for the modern human that has, is in a car all the time, that's on a computer all the time, that has the forward neck position, that has changed the curvature of the human spine from 60 years, where people used to be more rounded here, and now people are more back here, lower neck forward, and the suboccipital tendons are all jammed and shortened over time. I think that I've figured out a way to help many of them that may have thought that they needed like a much more escalated therapy and that they could probably get better with a much easier therapy. And what I mean that there's still a large percent that will need escalated, treatment, whether it's surgery, whether it's an incredible type of injection procedure from some of these doctors that are pushing the limits of what's possible with where you can put bone marrow. But I think that probably 70 or 80% of people that have CCI probably can recover with much less invasive treatments. And that's what I'm excited to raise awareness to the world, because not everybody's going to be able to get access to some of these specialty treatments, or do they have the means to afford them?
That's right, especially in Europe. That's
Yeah.
why we guys all fly in. But I mean, you already mentioned you're applying dry needling. So can you briefly explain what is dry needling? What is it doing?
Needling is creating a very careful and very specific injury to a tendon. So it's kind of like in that initial phase, if a tendon got weak or damaged or degenerated, and it's just from a slow strain, all you have to do is rest in the right position and give it gentle mobility, and the body will kind of heal it on its own. Now, if it's undergone a lot of deterioration and you didn't give it time to adequately heal, then it needs a little bit of a trigger to start to initiate that healing response again. So if you can carefully and correctly contact that tendon with a needle, it'll stimulate healing. It'll increase a little bit of blood flow in that area, and your body will start to remove the waste products and things that aren't supposed to be there and go back to the blueprint of how your body knows that tendon should look. And it'll start to, to strengthen it and reform it into a healthier tendon again.
Right. I mean, we were really puzzling and we were curious about dry needling. Yeah. I mean, Jonas, he was also treated with you and he explained a little bit here on my channel already in German how this procedure looks like. And it's very different that we think dry needling is. I really want to share a slide, what I Googled about dry needling. I hope you see my screen now. You see my screen?
Yes, I do.
Yeah. I mean, typically we have the trigger point dry needling where you do, dry needling into a muscular ball, tightness, and relax a special point in the muscle, which gives like some ease for the total muscle, right? That's the first thing I know. Then superficial dry needling, this is just in the skin. That I would say that's more or less the normal acupuncture, where you just needle in the skin and then you have a reaction on the skin and let also the levels below. And then you have the deep dry needling. So this is, I would say, not a trigger point needling, but muscular needling. And then I hope I pronounce it right, periosteal hacking, where you needle a bone to get an effect on nerves, I think. Yeah. So the way you do it, how would you describe it? It's probably deep dry needling, yeah. But it's not really written in the books yet. I need to admit, or I didn't at least find it.
So, well, maybe that's the point of the matter, is that there have been people that have been doing forms of tendon dry needling probably for a very long time, but to stress the significance or the importance of doing it often exclusively to bring a more long-term form of healing. And when you have a tendon that's degenerated for a very long time, remember, it will elongate. And if it elongates, that means that the coordination of that muscle isn't going to stop and hold the bones in the right position. So especially in the upper neck, that can contribute or lead to a form of instability. The kind of dry needling I do would most likely be called tendon dry needling, which some of the tendons are very superficial and some of the tendons are much deeper. And so it just depends on which tendon that we're trying to treat. But, once in a while, also, you have to try to feel in your exam, and also based on the diagnostics, is this one where the tendon is really kind of having a hard time staying connected right at the bone? Is it weaker there? And you will be barely contacting down to the tendon and osseous junction. So you're barely touching the bone right where the tendon connects. And other times the needle needs to be closer to the musculo-tendinous junction, which is right between where the muscle and the tendon connect. And often you can't be perfect with discerning it, but you can use high resolution or good ultrasound to get a clear picture of how the striations or how the fibers look, where it looks more degenerated or weak, and use that to aid in your treatment. But also, the more and more skilled that you get with using a needle, you can start to feel what kind of a tissue you're on. If you're sure this tendon is one you have to work on, and you're in that area, you've made sure you're not around any, blood vessels, you're in a safe zone, you're not close to any of the, major nerves. And, that's why you take a course in this. I took the MyoPain Seminars Functional Dry Needling course, which is the course that was the leftover or course that Janet Travell started. And she was really a marvelous physician. She was John F. Kennedy's doctor, the American president, and she lived to be over 100 years old. She founded the word functional dry needling. And she realized Kennedy needed a ton of injections. He had chronic pain. And she found that if she used just the needle, because she didn't want to expose him to all these injections she was giving him, that if she used just the needle, that she was able to generate a healing response and he was feeling better. So it's pretty interesting when you mentioned acupuncture versus dry needling. Acupuncture, if you really become an expert in it, from what I've heard, is that because I went to a school that taught a degree in acupuncture and oriental medicine, is that you could study it for 10, 15 years. If you go to some, Eastern countries, there are people that probably have put a needle into every spot in the body, but, they're not as much always into publicizing the study and why they did this one. And so, acupuncture is like an umbrella that can encompass almost any use of a needle. But, the acupuncture we commonly see in the States or maybe in Western Europe is usually very superficial. You're just trying to stimulate that chi response, which would be more comparable to that superficial dry needling. However, the way that it's approached from a legal standpoint is that you can call it dry needling if you're treating muscles, tendons, ligaments. And then if you're doing it to stimulate a chi response or to work on the meridian system to bring healing, putting a point in to help the large intestine, or then that's a form of acupuncture. So it's more the reason behind why you're putting that needle in. And, but yeah, when I took my 100 hours of acupuncture back probably 13 years ago now, or maybe 12 years ago, there were some points that our instructor showed us where they put a needle almost through the entire hip. I mean, they had a needle about like this long. So, acupuncture is pretty amazing and interesting as well.
Sure. Let's go a little bit to the procedure, how you do it, because I mean, I just showed the official types of needling. The way you do it is a little bit, I would say, different. Jonas reported it's quite intense, because a needling session takes up to an hour or an hour and a half, and you are quite, let's say, tired afterwards as a patient. And he also reported that the way he was standing was very different, right? So different muscles were, then he was standing in a different position afterwards. And you go in, but the normal way you do the needling, you go in and you go out, But you really go in and change the direction. And so can you describe a little bit this?
So, if a tendon, I'm using a very small needle, so it minimizes any risk of a side effect. It's an acupuncture needle. I think that it's 0.4 millimeters in diameter, if I'm correct. And that may not be correct, but I think that's what it is. And so, it's a very specific kind of a stimulation on that tendon, but the tendon might be significantly larger. So I want to find each spot that needs help on that tendon and contact it with that needle. And so I may be in one spot for upwards of a minute, and I'm getting to where I feel is the spot I need to start. And then I'll retract slightly and then move just maybe, a couple of millimeters over and then contact that tendon again. And in some areas where there might be 2 or 3 tendons that connect almost on the same spot on the bone, I mean, they're just barely off from each other. So sometimes in one insertion, you can also target a couple of different tendons as well, just depending on where you are, how safe it is, what else is around it. And yes, when people come in and they're trying to get a pretty quick change, a pretty quick result, they don't live local, we do try to challenge them to be able to tolerate a longer treatment than we would if you were living here in South Florida. We may only do, a 15 or a 20-minute session in a day and then have you come back the next week. But when we have 2 weeks and we have to try to make a significant change, we'll carefully challenge somebody's ability, but it sometimes can be, an hour long, the whole procedure.
Yeah. Brian, I also did a lot of strange things, a lot of strange treatments. So it wouldn't be I would be fine with it.
Uli,
Um,
this is an important point. I think you were going to ask me this question. Were you, but I don't think there's been any studies done yet to show how significant of a change in that tendon or a superficial ligament, if we're treating, um, how significant of a change happens on like a post follow-up ultrasound exam if you do this kind of delicate and gentle and thorough dry needling where you're contacting each spot on that tendon, what kind of healing. So I think probably I'll have to do one. I'll have to probably do a study to show, how much that we're actually changing those tendons.
yeah, would be great. I mean, if you have if you're a CCI patient, you go for any opportunity. Yeah, even if it's not really proved by studies, but of course it's something which also makes it more official for a wider number of doctors, I would say, because
Yeah.
normally doctors only believe in studies. Yeah,
Well, tendon dry needling already has some research that shows that it does
right.
help to regenerate the tendon. But just saying with the technique like we're talking about and
Yeah.
kind of
And
technique.
what I wanted to stress also now for the audience, like, I mean, you are an expert for the craniocervical area. So you do also dry needling in this spots here, yeah. And you also do a lot in the shoulder because the shoulder is also pulling at the first and second vertebrae. So this is all very connected. And I mean, you figured out that the problems up there very frequently also come from the shoulder, right?
Yes, yes. I think that, there have been many other doctors to come before me that have found parallels between, how your ankle is and your leg length, and that can cause your neck to go out. But I think that in the upper cervical instability community, that there might not have been enough appreciation for how that a shoulder or something else can pull your neck out of alignment. So you can continue getting your neck treated and neck treated and neck treated, but in certain individuals, it's always going to hit a plateau that you're not going to be able to pass until you fix the fact that this keeps tugging your neck out of alignment and increasing the amount of instability. So
Now,
hopefully maybe just I was able to help or I'm able to help a few people realize
sure.
that
I'm
earlier on so they
absolutely
don't spend
sure.
2 years treating the neck and then not making the progress they need.
Yeah. Very tricky question, Brian.
Well,
Why dry needling? Why not applying additionally glucose, PRP, maybe peptides, TB500, PPC 157, which is further
wow.
bumping, pushing the healing process?
Yeah, I mean, you could go ahead and just make a big cocktail and put all of them in there. No, I'm just kidding. And so, well, to be honest with this, I'm not the expert in regenerative injections. However, I have worked alongside regenerative practitioners for many years now, and you could go ahead and do those as well. But the reason that I do the tendon dry needling, first of all, is it falls within my scope of what I can do as a practitioner. And then second of all, is that it's less invasive, it's less dangerous, in my opinion, as long as you're skilled and able to do the treatment correctly and safely. You're not injecting anything foreign substance in the body. Of course, your own blood or your own bone marrow are not foreign substances, but you do have a risk of infection with that's greater than the dry needling. Um, Also, tendon dry needling works. I don't think there's anybody that would disagree that would say that if you actually contact a tendon or a superficial ligament with a needle, that it's going to stimulate a repair and regeneration response. It's going to help to reset it to a normal state. It's going to remove nerve ingrowth that's abnormal. It's going to help remove the little tiny vessels that shouldn't be in that tendon. So it works. And it's also, if people do it in this kind of a way, it could become accessible all over the globe, almost overnight, as far as the ability, you don't have to keep certain things at negative 80 degrees Celsius and have all these special, expensive labs and equipment. It's interesting because as much of the entrepreneurial mindset that I have, I spent 7 years working at a community health center in South Carolina where we served everybody, regardless if you were the CEO or you were homeless. And I've always wanted to provide solutions for people that can be taken anywhere. And it's not about, this is the only place that you can get this done. And, it's such a high access point that it's only for, like a few percent of the population. And I just think it's like a passion of mine to find a way to provide solutions for people that can become ubiquitous really easily and that will help whatever it is, whether it's 50% or 90% of people that have some form of instability, that you can start to get better, with something that's more cost, it's less cost, less invasive, and more accessible.
Ryan, you right now mentioned the reason why we need to found the Hutchason Academy. No kidding.
Oh, man.
Because you don't find so many doctors. Maybe there are some who do dry needling, but in this area, you need to have special knowledge. So, which is not
You need to
available
be
on a
careful
smaller
for
scale.
sure. I mean, I spent probably since I bought a digital motion X-ray in 2015, I've been really honing in on the upper cervical spine. And then I've, gotten training in upper cervical chiropractic. I've been working alongside regenerative medicine injection doctors since right after I got the digital motion X-ray. So, and even in more detail at full immersion for a couple of years. And then, just kept studying and studying and studying. So yeah, I mean, you definitely need to have some training in it. It's not just, really easy at the beginning.
Yeah. Brian, we want to have also a look on maybe challenge a little bit dry needling. And I'm very happy that one of the global expert for cranio cervical instability recently also post a YouTube video. Yeah, it's Chris Santino, and he posted this video: Can tendon dry needling fix CCI? And he did some statements there, and I mean, I really honor him. He is really one of the biggest experts in stem cell treatments and also PRP and Prolo, maybe more PRP. But I would like to reflect a little bit of his statements and where you can give your experience of how you see the things, right? I mean, he was saying that the ligaments are the or let's put it the other way around. The muscles do the stabilization of the joint in the movement, and the ligaments do then limit the range of motion. Like if you have a finger, the muscle move, right, and give stability in the movement. And then if you want to bend it backwards, it's the ligament who do the limit of this, right? And he says, okay, if you do dry needling, right, you can work on this middle range of instability, but you will not work on the limit of motion, right? If this is excessive. So this, I think, is his statement here. I would like to have your opinion on this. Is this also what you see in your praxis, or you see it different?
Well, first of all, I just want to agree with you that Dr. Centeno has been a leader in his field since probably I was in diapers. So I have tremendous respect for what he's done with regenerative medicine and how he's finding new ways to treat individuals that fall through the cracks in healthcare. And also, I really appreciate that he did do this video and that he did say that, treating the tendons with dry needling to the suboccipital region is helpful, and how he's commented on that the muscles and tendons are half of the battle when it comes to spinal stability, and the ligaments, the part that, he more so focuses on. Of course, he could probably do anything if he wanted to with an injection, but he's more focused on some of those hard to reach ligaments. From what I see on his channel, is that, he said that's more half the battle. So I really appreciate that. And if your tendons are super strong and they're working correctly, and you're doing an active motion, such as bending like this, and you're controlling your motion, they still are limiting motion. So they are weaker when they're in their fully extended range. Like, how much weight can you lift with a bicep curl if you take your arm all the way to here and you start that motion? It's going to be a lot less than if you start it here and you lift it. So they're not as functional, but they still are working while you're in a maximally elongated position. Your tendons still do have a contributing factor to functional stability, meaning while you're active. If you passively take the head and you're not using the muscles at all, and you just completely stretch it as far as you can, you're going to get a clearer picture of the ligamentous portion of spinal stability. And that was, I think, the response to that question. I think you have a few more too.
Yeah, it's another slide. I mean, I share again.
This showed me these like 2 seconds before we started the video. So yeah.
Yeah, I don't want you to be prepared.
No, it's good. This is great. Yeah.
No, it's like what he's saying here in his conclusion is like that he has the experience that the effects on dry needling are more short-term, that it's not sustainable, that it's not really changing the picture.
I brought one patient in today just to share her journey with the tendon dry needling, that has been through, a lot of regenerative medicine as well, and tendon dry needling. And so, I mean, I think that that's better not, told from me. I've never wanted to be the doctor that's like, I've got the answer to everybody's problems. But at the same time, I've personally seen many people that are getting long-term results from tendon dry needling. Even an individual that had a little tiny, meaning a thin and petite lady that had a terrible trauma. I posted a video about her on my page, and she had a lot of upper cervical ligamentous instability and severe POTS. And she's now like, she hasn't seen me for several months, and she's not 100% better, but she hasn't regressed. I mean, she's doing great. So I think that it just depends. That's why I think that the technique, the little tiny bit of the different approach, may be valuable. And hopefully over time, I'll be able to provide more insight into how that we're able to get some long lasting changes. And I do also believe it's valuable. If you have ligamentous instability, you should, of course, consider addressing it. But often with the kind of tendon dry needling I'm doing, people are getting, if it's working for them, which, I've had probably 4 patients last year that I wasn't able to turn the needle for, meaning they didn't get, really much change. But I had a lot of people that got 20% better, 40% better, 70% better, even more, 90% better. And it happens pretty quick, with the kind of work that I do. Within the first month or two, you should know, like, you're starting to get better. And sometimes I think that's a better way to start off with, like, I have several individuals that were bedridden, not able to do anything. And now they're like, I can walk around for 20 minutes and I'm up. And it's like, that's probably better to get you there first, and then to start thinking about some things that you might not be able to do any rehab for several months after you get a big procedure done and you're still in bed, so it's like, I want to try to return some of that function as quick as we can, and then see whatever else we might need to do.
Right, you have her with you today, right?
Yes, I do. Do you want to meet Tara?
Yes,
Okay,
sure.
good. All right, let me go ahead and turn this, okay? All right, give me just a moment. Okay, good. Yeah. Right. So get this turned around
Super.
here.
Hi, Tara. Nice to have you here.
Nice to be here.
All right. So first of all,
Yeah.
Tara has been sitting like this for probably an hour now, which you probably couldn't have done a few months ago.
No.
Is that okay, Uli, with the camera?
If you come a little bit closer because of the, I think it's a little bit low
Okay.
from the microphone side, right? So exactly, perfect.
How's
Yeah,
That's
you
good.
look happy. Tell us a little bit about your story, Tara.
Yeah, so I have been in the regenerative space now. I saw Dr. Hauser starting in October of 2021, and I was far away. I was on the West Coast of the United States. I was traveling. So I did 3 appointments in about a 9-month period. So between October of 2021 and August of 2022, I saw him 3 times. And then we moved here to Florida to get treatment for me. And I saw him just doing first prolotherapy. I've done 9 sessions total, and I did 7 of just prolotherapy. And then the last 2 have been prolo and PRP. So we did my lower back and neck. We did August of 2022, September of 2022, October, November. And then we took a break, and then we did February of 2023. And then my last session with him was in July of 2023. So I've had 9 sessions total. I saw Brian in the beginning when I saw Dr. Hauser. We were trying neck weights with me. We tried the halo. We tried the forward and the back. Yeah. I couldn't handle the halo. I had so much instability.
Sorry. There we go.
Oh, yeah. Sorry. I had so much instability that it caused a lot of symptoms. So I did the lower neck weights that whole time up through probably last spring. So spring of 2023. Wasn't seeing Brian most of that 2022, early 2023 period because he left working with Dr. Hauser in October. So took a break from that, but was still trying to do the neck weights. And then I started seeing him last July. My history is I probably had a few childhood incidents, like a couple falls on the tailbone, hit in the head with a basketball one time that probably created a little bit of instability in childhood, but no neck symptoms. And then in my mid to late 20s, I got rear-ended. So I had an auto accident. Wasn't a bad accident in terms of a lot of damage to the car, but I was parked and just took the whole impact of it. So I got more of the impact than my car really did. And that sort of started me on the process. I had chronic pain for a couple of years, did a lot of chiropractic treatments. They sort of got me to a stable place, and I wasn't having continuous pain. From that point, I could never do pounding things. Like I couldn't run, I couldn't do anything that would stimulate this occipital area, would just cause a lot of pain. But I could pretty much function in life. I could still do some stuff, but just not any, like I couldn't play tennis and run, things I used to do. And then in the fall of 2019, it really kicked off, I think, post-viral infection. And just all my symptoms inflamed so bad. And I was having a number of symptoms from my lower back up to my neck, a lot of like foot drag, vertigo, just a myriad of symptoms. And it took me about 8 months to just figure out that a lot of it was coming from my neck because it seemed sort of whole body. And that's when I started finding Dr. Hauser in June of 2020. So then a full 1.5 years later is when I started seeing him. So I don't know what doing tendon therapy would be versus the PRP. Sorry, I know this is a lot of background, but a lot of my symptoms, apart from just the visual, tinnitus, vertigo, foot drag, drop, things like that, I had a lot of like neurological jolts and shocks and things. After about my 3rd PRP, those got much better and they've continued to get better. They could still be there, but they continue to be. I was never on full bed rest, but I couldn't walk very long or do things without having a lot of neck pain and a lot of symptoms. And it's gradually improved. I can walk a lot more now. I can walk a few miles. I do pool exercises. I don't swim because I can't do things like that. But I'm able to walk and I'm able to do pool exercises where I put like a life vest around my waist and I can kind of bicycle. So those are my main forms of exercise. But I got that initial stability from the PRP, which really helped. And then I was working on getting my neck curve, and Dr. Hauser kept saying, we need to get a curve in your neck so that you can really get to that healing, but nothing was working and the weights weren't really working. And it was always pulling back out. And I was getting a lot of the visual nausea symptoms, just trying to do basic things like being online, reading books. I wear a cervical collar for those things. So then I saw Brian in June or July of this year, and we've been slowly doing tendon treatments. We don't do them every week. We did about 3 in a row over the course of a month and a half, took a couple months breaks, and then we did some more. And in the last, probably did another like 3 or 4 over the course of last fall. And then in the last, I think we've had 3 or 4 treatments since the beginning of this year. But each time we talk about it kind of like, sort of like if my neck was the Eiffel Tower, you sort of work on different parts of the structure. So in the beginning, he did a lot of work at my occipitals because I had a lot of tightness there. And that initially with the dry needling, it sort of loosens things up. Like I could hold my head. I was always forward and my chin up, and I couldn't quite pull my neck in like this. Instead, it was like to try and pull it in like this, I would end up trying to jerk it back like this.
Yeah.
And that would create all sorts of symptoms, visually, tinnitus, maybe some more nerves, shock, jolt symptoms. So slowly over time, that's come in where my posture's gotten better, and I can hold my neck. And I noticed over time, like when I would sit down and I could be for periods of time on my computer without a neck brace. Maybe I think one time right after treatment, it was like an hour. And it does tend to wane over time, but still the position is much better. And then we've slowly worked down the neck. And now we're doing a lot of the shoulders and the back scapula because a lot of the pain goes down. And with each session, there's just a little bit more stability. So there's a little more softness in my neck and a little more stability. Some of the core issues are still there, like trying to be online. If I'm looking down for periods of time are still there, but my duration that I can do all those things is getting longer. Some of them it's only a couple minutes, like if I can look down before I'll start to have symptoms. But some of them, like being on a screen, might be anywhere from like I can do 10 or 20 minutes to maybe an hour or more. So it's progressively getting better. Sometimes after a treatment, it's sort of like you're stirring the pot. So there are sometimes a little bit of disorienting symptoms for a few days or maybe even a few weeks while you're treating an area. And Dr. Bryan's explained to me that that's sort of like this, the tendons as they heal, then the muscles can sort of heal around it. So everything in the structure's kind of got to get more stable, but it might be a little wobbly until it holds up, but it definitely has progressed. And I wouldn't say, while my symptoms are still there, I wouldn't say that it's necessarily a reoccurrence of things or they've weakened. I think it just keeps pointing to where you have degeneration in the neck. And I had degeneration at spots, I think C4, C5 or C3, C4, and then definitely C0, C1. Dr. Hauser diagnosed me with extreme ligamental instability. I had I think like 5 or 6 millimeters when you had this way, the ligaments going over.
Okay. Yeah. I mean, we are very similar from our history.
Oh.
Because, I mean, you can just speculate what was the root cause, but I also had some incidents in my childhood. Then I hope I pronounce right, the tonsils, yeah, are area of disturbance very much. So the drainage from the brain on the left side cannot be accurate, right? So I also had a hearing collapse on the left ear, which I connect to also this that the poison cannot go out of the left side of the head. And I could manage it for many, many years, but over life, things add up and add up and add up. And then you have Lyme disease, which is also not good for the ligaments. You have another car accident, but it did not immediately come after the car accident. It really took time, years. And then, of course, I'm a very tall person. I'm 1.90 meters. Yeah. So you look all the time, you look downwards, and posture was very terrible. I'm still working on it, but very similar from our history. And exercises, I do something which is also very crazy. Tara. I can do inline skating, yeah, which is if I have an accident, right? It's horrible, but it's smooth, right? You stand upright, you don't bend your neck, and you need to do something which makes fun, yeah, to just get the mind away from the disease and also show the body that he can move. Yeah, that you can do an exercise, that you're not bounded to the bed, right? So I'm very happy to hear your story. And I mean, I would say it's a severe, it was like 6 millimeters, that's more, it's a severe instability. With the dry needling, can you say where you're right now?
Yeah, I was thinking about that while you guys were talking. I would say that if I compare myself to my old active self, even my active self post after having a car accident, I would say I'm still less, like somewhere between 40 to 50% of that person, because I can't do physical things without it really starting to start, like even just things like cleaning your house. If I'm bent over too much or I'm doing things the wrong way, it's a lot of symptoms. But from where I was last spring when I went to see Brian, I would say I've had at least in these areas, I've had at least anywhere from a 25 to 40% improvement in certain areas. Like, especially in my occipitals, a lot of the times they just aren't bothering me as much. They're not being pulled out all the time. So this area, I'd say it's at least a 40% improvement in here. And now we're starting to work down in here. And I saw him last week, and I was having a lot of, tension back here in the mid back. And that's decreased at least 20% in the course of a week with him working on my shoulder. So, I'm still less than 50% of my old self, but I'm 80% of where I was in terms of the journey of moving things back.
My question was also in terms of millimeters of range of
millimeters.
motion.
We could repeat that.
Yeah, we hadn't
done one. So
anyway,
Tara's been very careful, with her recovery, and
we've
over the last year, we've only treated you maybe 10 times or
yes.
So we went like 3 weeks in a row, and then we took a break, and then so she's only probably had about 10 times, and in those long breaks, it never regressed back to baseline. Like the progress, I think the important point here when we brought her in was that, it never regressed back to baseline. So like the changes are continuing. And we also have she hasn't gotten any of the hour-long treatments. We're usually a little bit more careful. It's very uncomfortable for her. And so I might only do just the suboccipitals, and then we might do, the splenius that connects from the, the upper back to the head. And then, so we have to get all of the coordination of the tendons that connect up to the head and the upper neck.
I think we could check, because we did a DMX when I first saw you in June.
We could go do one right now.
We could.
No, it's fine. I mean, we also proved it that immediately after the dry needling, that it's in many cases, Brian showed that the instability is much less, right? So
that's the other thing, Willie, is that it's not always much less. Like it's not always like it goes from a 7 to a 3, but there is a component of stability of the spine that has to do with the tendons. And I think that the other part there is that there won't be as many symptoms even at end range too, because you still have the effect of the muscle and tendon doing some work there instead of having a weak tendon and a weak ligament. And another thing is that a capsular ligament at C1, C2, I looked it up a long time ago, but let's say, I don't remember the number, but it was either like 25 millimeters in length or something like that. And it can stretch up to 6 or 8% or even more without experiencing any injury. So you might have, 2.5, 3 millimeters of overhang and have no real problem with that ligament.
Right. I mean, a good example is you.
What's that?
A good example is you. You also have an overhang.
Yeah, I mean, I had 7 and 5. Now, last time I checked, it was 5 and 3.5.
Yeah.
And I mean, so that's just another thing to consider. But we should do. I mean, I would like to do more, because we have had several people where it's decreased by a collective 2 millimeters, like 1.3 to the side and 0.8 to the side. And then I've checked on them months later, and they said they're still fine. They get no more clicking and popping. You know, they have no more brain fog. So I think small changes, you know, can be made from overhang just from increasing the strength of all the tendons, for sure.
But we will do that, and he can follow up with you, because we have my numbers from Dr. Hauser in February, and then we can do when I started seeing him in July.
Yeah,
we'll do one.
Great.
We'll do
Likes that. You see, he's like, oh.
Ultrasounds. And the interesting thing was, I'm very closed on your left side, I'm on my right side. And I had, but both were very closed when I first saw Dr. Hauser, and this side opened up pretty much close to, let's say, from 50% to 1. This side has pretty much stayed the same. So, and we checked it recently, we checked it not recently, we checked it the end of last summer, and it was still kind of the same when I'm sitting up, but we'll check it again and see. My sense is that it's doing better, because I don't get as much pulsatile tinnitus. It used to be every time I bent over, I would have tinnitus pretty common, just sitting like this. And then when I would bend over, it would just be that whooshing in your ears. And that's one of the things that went away sometime last summer. And it wasn't immediately after a treatment. It was like a treatment, and then a few weeks without it. And then it just sort of over the course of time, I noticed it wasn't there. So things like that are improving.
That's great.
Yeah, that was a huge one.
And Tara's considering
confirm it's sustainable, right? It's not like you do a treatment and after 3 weeks, you need to do it again. So you have long periods between your treatments, and it's always improving. And that's kind of proof. I mean, Brian, as I said, not everything fits for everybody. Shit.
Yeah.
Not every treatment fits for everybody. You need to try. Yeah. And I think dry needling is indeed a method which is a try worth. Yeah. Unfortunately, you're too far away. What I'm currently doing, I have a therapist. I said before, I do also crazy things. He's giving me an injection into the facet joints in the upper back, but not here in the neck. And then with the pressure bottle, he is pumping CO2 into me to stretch the tissue from inside. And this is going up the total spine. And I have a tremendous reaction on the nerve system afterwards. So I need a couple of hours to calm down. But it's like very intensive stretching from inside. So this is also something very interesting I for example, do. It's not on the tendons, it's clear, but it's on the fascias more, yeah, and also very effective. So there are many things, yeah. You need to find what's helping you. Is it stem cells? Is it PRP? I tried PRP as well. Is it Prolo? Or is it dry needling? And I think today we had a very, very good session, I hope, on the dry needling to get some more knowledge on this topic, because there is not too much right now on the internet, especially not so long sessions like we had today. But if you are interested, you will watch it. So it's not a 10-minute session here, but I mean, it's a complex topic, and I think I would like to really thank you both, Tara, also that you came to Brian and gave us a little bit an insight of a patient, right? And how this works as a patient is always better than like Brian is telling he's doing miracles, which he's doing. Yeah. I think something else you wanted to add, which we did not touch, I did not ask, or
anything else that you wanted to add?
The only other thing I would say in thinking about it is that just when you talked about movement with the inline skating, I am moving more now, and it's like the movement begets more movement, and I can do more things in more of a range of motion without as much immediate pain. And it's hard to quantify that, because it's sort of like, oh, I can reach for this thing and I didn't get a pain response like I would have had before. I didn't like I can feel I can move more in this area without it creating either neurological, visual, auditory symptoms, or just a pain response. That's the thing I think about the tendon dry needling that's been really interesting to see, is that over time, it's like the fascia starts to release a little bit, the tendons and ligaments get more stable, and the body can just move a little bit more. And I think that's really helpful, because you can start to get so restricted with CCI where you just stop moving because you're just trying to be stable, and then it feels like you're almost in a cage.
I think it's also psychologically, it's very important that you don't feel sick all the time. Because I think the mind is also a very important factor for the healing. I did also some work on the mind, because deep within me, I did not believe that I can get sound again. And if you don't think it, yeah. Of course, I wanted to, but if this stresses you, of course, this is a factor which is blocking the healing process. So if you can do more, it's turning a lot of things. Yeah.
Yeah, we're turning the boat around slowly.
Yeah, exactly. Yeah. And it's important to have progress, that you have hope. Because if you don't have hope, it's hopeless. Okay, I don't find the right words,
No, I agree with everything you're saying. I think that when you're so lost in your symptoms and it feels like it's coming from all sorts of places and you don't know what's going on, it can feel very overwhelming. But there are just little things, and every time your body gets that safety signal and just a tiny bit of stability, it compounds, because then the body knows, oh, I remember this, and it builds on it. That's been my experience. So
yeah,
which I'm very grateful for, because when you are in the middle of the storm, it's hard to remember life before that.
So thank you for you guys. Yeah. If you like the videos, give us a like. Look also, I'm not sure, Brian, whether you also will post this, because this is a long video. But
yeah, of course.
From my audience, also visit the channel of Brian. He's also doing great videos on different topics and giving more insights. And I really recommend this. And yeah, if you like it, give us a like, or also an abo. And yeah, I hope that we could bring some more knowledge to you today. And I wish you to get sound very soon. Thank you also to the United States.